Hello, and welcome to today's Better Care Playbook webinar made possible through the support of the Seven Foundation Collaborative. Today, our topic is Addressing Food Insecurity for Medicaid Populations, Lessons from North Carolina's Healthy Opportunities Pilots. My name is Amanda Bank, and I'm a program officer at the Center for Healthcare Strategies. On the next slide, we'll go through some logistics. To eliminate background noise, audio lines are being muted during today's event. However, we do want to hear from you, and there will be a Q&A session towards the end of the webinar. We encourage you to submit a question anytime by clicking the Q&A icon located at the bottom of your screen. Today's event will also be recorded and shared publicly on the bettercareplaybook.org. On the next few slides, I'll review our agenda and introduce our speakers. I am so excited for the agenda today. We'll start with introductions, including our panelists, and then I'll share a brief overview of food as medicine interventions just to ground the conversation. But then I'll turn it over to our panelists who will share insights of the Healthy Opportunities Pilots program based on their experiences as implementers and as an evaluator. And then again, we'll end with a moderated Q&A. So as questions come to you throughout the webinar, please drop them in that Q&A box located below, and we'll get to as many of them as possible. I will quickly now introduce you to the Better Care Playbook. For those of you who may not be familiar, the Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. Every month, the Playbook summarizes new journal articles, evaluations, and implementation tools, and also develops resources like this webinar, which are designed to help translate evidence and research into practice. You can explore the playbook at bettercareplaybook.org, and on the next slide is some information about our funders. So the playbook is coordinated by the Center for Healthcare Strategies through support from these leading national healthcare foundations whose names are listed here on this slide. We are so grateful to our funders for making it possible to bring us all together today. And next, I will introduce our guests. So again, I'm Amanda Bank. I'm a program officer here at the Center for Healthcare Strategies. I spend most of my time thinking about how to best coordinate Medicaid and food and nutrition security efforts. And now to introduce our esteemed panelists in no particular order, I'd first like to welcome Sarah Rideow. Sarah is the Healthy Opportunities Pilots, or HOP Program Director for Community Care of the Lower Cape Fear, or CCLCF, where she focuses on implementation, planning, and evaluation of the HOP program, along with an incredibly talented team and network of human services organizations, which are what community-based organizations are known as in North Carolina, within a 6-county region. Sarah's previous work includes leading communications and grant writing for CCLCF and grant management and compliance for a program funded by the Assistance to Firefighters grant through FEMA. Up next, we have Christopher Crooks, who goes by CJ. CJ Crooks is the Executive Director of Onslow Community Outreach, or OCO, which is a nonprofit serving Onslow County for over 35 years with vital programs including food security, emergency shelter, and community health services. Since joining in 2021, CJ has led a successful capital campaign to expand the organization's housing support center and lead OCO's involvement in the Healthy Opportunities Pilots program. He has a background in leadership and development and nonprofit consulting and a history of helping organizations strengthen their missions through change management and fundraising strategies. And last but not least, we have Dr. Seth Berkowitz. Dr. Berkowitz is an associate professor of medicine and section chief for research at the University of North Carolina at Chapel Hill School of Medicine in the Division of General Medicine and Clinical Epidemiology. He is a general internist and primary care doctor and studies the relationship between health-related social needs such as food insecurity and health outcomes. He is the lead evaluator for the North Carolina Healthy Opportunities Pilots and Deputy Scientific Director for the American Heart Association's Healthcare by Food initiative. He is also the author of the recent book, Equal Care, Health Equity, Social Democracy, and the Egalitarian State, which examines how public policy can improve population health. So clearly, we have a talented and passionate group with us today, but before I turn it over to them, I'll just give a brief overview of food as medicine interventions to ground us all in what this webinar will be about. So, as noted on the slide, the term food as medicine, or FIM for short, can be defined as systematically integrating healthy food into the healthcare sector with the aims of improved health outcomes and lower healthcare costs for people with specific clinical conditions. We all know intuitively that access to healthy, nutritious food is critical to overall health. But I just wanted to highlight a few key outcomes that we know are impacted by food as medicine services. I won't read all of the ones on the screen, but some of them include improved diet-related health outcomes, including A1C levels, blood pressure. It also includes lower healthcare spending, fewer hospitalizations and ED visits, and increased cross-sector collaboration and investment in under-resourced communities. And we'll hear a lot more about all of these outcomes today from our panelists. On the next slide, we can see the food as medicine pyramid, which is really just a useful framework showing the range of food as medicine interventions, which can be tailored to an individual's level of need. So at the bottom of the pyramid, we have population level healthy food programs, all the way to more intensive treatments for more specific health needs at the top of the pyramid. And it's really critical that all of these services are coordinated so individuals accessing shorter term, more intensive food as medicine services like medically tailored meals are also able to easily obtain longer term food as medicine services to ensure that an individual's overall health and food needs are being met across the lifespan. So on the next slide, I'll briefly note what food as medicine can look like in practice. First, it includes those food as medicine interventions listed in the pyramid, like medically tailored meals, nutrition prescriptions, grocery provisions, and nutrition counseling. It also includes food and nutrition security screening and referrals from providers. It includes federal benefit programs like SNAP and WIC and enrollment assistance, including case management into those programs. And finally, it includes community food infrastructure and programs. In some states, that looks like specific community reinvestment requirements for managed care organizations to reinvest a portion of their profits back into the community in different ways, often with a specific focus on resources to address individuals' health-related social needs, including food and nutrition insecurity. Medicaid programs have authorized health-related social needs interventions through various authorities, including Section 1115 waivers, such as the North Carolina initiative featured in today's webinar. While North Carolina's Healthy Opportunities pilots has shown really strong results, its future, like other state efforts, depends on an ever-evolving state and federal budget and policy priorities. Despite recent news that North Carolina may end this initiative early, we look forward to hearing insights from the pilot, which can inform similar efforts across the country to improve the health of Medicaid members. And so, without further ado, I am happy to pass things off to Sarah Rideout, who will share a lot more about the Healthy Opportunities pilots and her organization's work within the program. Sarah, take it away.
Great. Thank you, Amanda. Again, my name is Sarah Rideout. I'm with Community Care of the Lower Cape Fear, and we were chosen as one of the 3 network leads for the Healthy Opportunities pilot. Next slide. So just a little bit of background. I'm going to talk a little bit about Healthy Opportunities Pilot overall, recognizing that there is a focus on food and food as medicine here today. But I did just want to share a little bit of the background of why North Carolina decided to even come up with something like Healthy Opportunities Pilot. We know that there's a lot of social drivers of health and needs across the country, but in North Carolina alone, these are just a few statistics and a little bit of data just to show exactly why Healthy Opportunities was put together and developed. So, and again, some of this data, the years vary, but here you can see about 1 in 28 of North Carolina's children under 6 are homeless with about 1.2 million or so that cannot find affordable housing. North Carolina has about the 8th highest rate of food insecurity in the United States, with about 1 in 5 children living in a food insecure household. So again, I won't go through all of this, but this is really some of the reason that you can see North Carolina chose to really address and put together the Healthy Opportunities Pilot. So next. So what is the Healthy Opportunities Pilot? Center of Medicaid and Medicare Services had authorized up to $650 million for both state and federal funding to test these evidence-based non-medical interventions in healthcare. So when I say CMS authorized, that's exactly what it is. It's not that the funding is there. It's that CMS authorized up to $650 million in state and federal funding to test what we call services, but also we call them non-medical interventions in healthcare. So really what we're here to do in Healthy Opportunities Pilot is to test these services that fall under 4 different areas. That would be housing insecurity, transportation issues, food insecurity, and then interpersonal safety. Sometimes we call that IPV, or interpersonal violence or toxic stress. And those non-medical interventions or services fall under those domains. And what we're really here to do, those overarching goals, is to see if we can, through these interventions, improve health outcomes and reduce healthcare costs for a subset of Medicaid enrollees. And I'll talk a little bit about what it means to be an enrollee in HOP in a little bit. So next. So why is HOP important and why is it different? We've been asked a lot, especially lately, what is the difference between Healthy Opportunities Pilot and then maybe working with the regular, human service organizations or community-based organizations that are already in the community, which provide incredibly critical care in our communities. But what makes HOP different is we really are collecting that critical data, because what we're trying to do is really tie it to health outcomes and a reduction of healthcare costs. So, for example, for a healthy food box, there are a lot of amazing organizations in our region that provide food boxes. But in Healthy Opportunities, we have very strict guidelines as to what can go in those food boxes. So it's considered a healthy food box where we can then tie it to the health outcomes and then that reduction of healthcare costs. So that's one reason HOP is really important. So we're collecting that critical data. We're really looking at those social determinants of health. So again, beyond food, we're really looking at housing and transportation, as well as IPV and toxic stress. And then I think another really critical piece to Healthy Opportunities is it's helping to bridge the gap between the social and healthcare needs. So somebody may come into the pilot through their doctor's office, and then they have that insecurity. So the bridge is that way. But a lot of times people are coming in because they have that food insecurity or that housing insecurity or a need in that space. And then in Healthy Opportunities, then they're connected to their care manager at their health plan. So it's connecting them back to the healthcare portion. And that's another critical piece of Healthy Opportunities. So, what's the workflow? There are a lot of stakeholders in Healthy Opportunities Pilot, which is really exciting, because if you've ever seen, and you can look at the list of folks here on this particular slide, not you don't always see all these groups come together, right? Sometimes there's a lot of isolation in how this work is done in order to support anybody's needs. But in Healthy Opportunities, really, you have a lot of different stakeholders that had to learn how to work together, bring their workflows together, which was really interesting. Again, pilot, right? So there's a lot of evolution in this pilot. There's a lot of learning, and there's a lot of collaboration across. So the prepaid health plans, care managers, network leads, which is what we are, and of course the human service organizations, and then lots of different groups that are coming together. Okay, so I talked about this a little bit, but we really are here again, Healthy Opportunities Pilot, to really leverage the evaluation findings to see what we learned. So if we learn that some of the non-medical interventions do support those health outcomes, they do reduce healthcare costs, and we live in that budget neutral space, then we begin to leverage the pilot evaluation findings, and the hopes are to embed them in North Carolina Medicaid. So, just a little bit about the three pilot regions in North Carolina. Um, like you can see here on the screen, right now there are 33 counties participating in Healthy Opportunities Pilot. Community Care of the Lower Cape Fear is in the green. So I am the program director of these 6 counties. So we're all testing the same framework of healthy opportunities in a lot of different regions. And a lot of the counties that you see in the pilot regions are rural communities. So there's a lot of rural communities that are in the pilot right now. So again, just a little bit of description of what these non-medical interventions are under the food, housing, transportation, interpersonal safety, and then cross-domain. And those services are ones that can kind of cross through the other 4 buckets. And so you can see there's a lot of different services that are provided to those that are enrolled. Typically, what we see is a member receives more than one service. So somebody may be receiving a food box, but they may also be receiving transportation to a job interview, or maybe they need housing navigation in order to help support them into a new, safe, and affordable place to live. So, since we are here focused on food, I wanted to give some examples more around the food space. So, again, what does that look like for our food services? Those healthy food boxes, a member would receive those once a week for usually there's a 3 month and 6 month check in with that member's care manager. So, then the person does receive those food boxes once a week for a defined amount of time. Right now, there's diabetes prevention classes that are also part of the program. And as Amanda had sort of described before, there's healthy meals that somebody can receive as well as medically tailored meals. So there are a lot of different examples of what non-medical interventions look like. And on the next slide, what you can see is just some really good examples of what this is at the bottom left-hand side. You can see that is our food sector. So we have 44 human service organizations total in our 6 county region. And some of those are our food sector providers. And that is a food sector meeting with all of the folks that are contracted to provide those non-medical interventions in our region. You can see what an example of what goes into a food box. And I think what's really interesting about the pilot is we do a lot of work with local farmers and local vendors and local contractors. So there's a real economic impact that goes into healthy opportunities. It's not just about working with the member. We're really working with our local farmers. We are creating jobs because there's a lot of jobs that come out of Healthy Opportunities Pilot in our rural communities, which is not always easy to find work in a rural community. And then we're working with local contractors. So somebody may be building a ramp that is a local contractor or getting materials from a local business. So it's really bigger than just what we get to do to serve the member and collect the data. So this is just, again, some great examples. If you see on the left, these are actual pictures from what members have made from their healthy food boxes. So you can see members, and when they receive, for example, a healthy food box, they'll get a recipe included because, maybe not everybody knows how to make or use eggplant. And then, or they'll receive education on, if anybody's seen the My Plate, where it shows different portion sizes. So there's a lot of education that goes in along with just the healthy food box. And you can see we've already gotten some really great feedback where people understand, like, this is helping to maintain my diabetes. And then just again, I like to go back to the site social isolation portion, right? You can see at this bottom one that this person just is so excited to have their HSO, that human service organization touch point, and they get to know them and they get to trust them, and then they feel a part of that process, which is really exciting. Which is also kind of cool is, let's say somebody delivers a food box and they get to know that person, then all of a sudden they're like, their windows are open and their windows have always been closed. And in North Carolina, it gets very, very hot. So why is that? And so they'll talk to the member and the member will say, my air conditioning broke. Well, then that food box deliverer will go back to somebody else in Healthy Opportunities Pilot and get to do another referral to support that person. So again, it's bigger. It's becoming a real big community and a support effort around that member. Next slide, please. So I know I have just a little bit of time left, but I wanted to really quickly go through how you're eligible for Healthy Opportunities. And again, I won't go through everything, but I'll share just this information. Is there is some qualifications right now. You need to be in Medicaid, North Carolina Medicaid managed care, either in the standard plan or the tailored plan. But right now, the eligibility is around physical or behavioral health criteria, where you need to have one or more chronic conditions, and that varies by population. The slides will be available to you, so you'll be able to see what that looks like. And then one social need. So again, you need to have a one or more chronic health conditions plus one social driver of health to currently be eligible in the Healthy Opportunities Pilot. And I wanted to, if I could, as we wrap it up, you can click one more over and go down to just some of the key metrics. And again, you'll be able to get these, so you'll be able to see those. This one will land on this one. These are just some really great key metrics in the pilot regions, and this is across all 33 counties, but we've made a huge impact in our communities. And Dr. Berkowitz is going to talk more about that data. But overall, all 33 counties, over 1 million services have been delivered to our HOP enrollees. So that's just a huge amount of food boxes, healthy meals, medically tailored meals, housing navigation, essential utilities, transportation to a job interview or a grocery store, somebody receiving violence intervention services if they've experienced that in their communities. So again, just want to end by saying there's a huge amount of work that's been completed so far in this very short period of time in Healthy Opportunities.
Thank you, Sarah. Ooh, I think, am I next or is Seth moving?
TJ, you're next.
Okay.
If you want to go back a few slides.
Yeah, if we can go back a few slides to start at Onslow Community Outreach. So I think that it's important when you're looking at if a project is something you want to take on as a community service organization, does it meet your mission? So a little bit about Onslow Community Outreach, if we can go to the next slide, talks about a bit of our core programs. In 1990, we started as a soup kitchen, and we had come together as a community and worked a lot with Christmas projects and programs. And in a year of abundance, the group that had done a lot of these Christmas programs said, people have needs outside of Christmas. Let's start where we know there's an issue of food insecurity and start with a soup kitchen. So in February of 1990, a group got together and they had a huge network of individuals and churches. They made a phenomenal lunch. They had a press conference, and no one came out for that first day at the soup kitchen, which was exciting in some regards and kind of a testament to, we know this is a need, we're going to continue doing it in that grid of North Carolina. So From there, Onslow Community Outreach, and a few years later, had talked with participants who were in that program and said, what else is the need? So we started an emergency homeless shelter. So we have a congregate shelter that's now grown to 44 overnight beds. And our most recent programs are healthcare services. So we have a free and charitable clinic through the North Carolina Association of Free and Charitable Clinics, where we're doing medical and dental services. The programs inside of HOP, as we've heard of, food as medicine, really fit well into our core services and what we were already doing. So this was an opportunity we jumped at. Next slide. Now, we heard Sarah talk a little bit about the food box, and I think I'm going to spend the time that I have focusing on that portion of this program. Now, when we hear food box, that immediately puts us into quote unquote a box, right? So we had to think outside of that immediately, because it's not just a box. When we're thinking of this food prescription to help with someone's nutrition, really we need to kind of see what this is. And on the slide, you have a picture of one of our very early food boxes. We had talked with staff and participants from our different programs and said, what is it that you use on a weekly basis, knowing that this box is going to come out weekly, and then fitting that into program guidelines. As Sarah mentioned, the program guidelines are pretty specific, that we need to have so many units of fresh fruits and fresh vegetables, so many units of protein and dairy, our whole grains, a little bit of oils. So as we were doing this, we started coming up with boxes, and we were so excited by our boxes. And one of the challenges that I think is important to share with you all as you think that you may be getting into this is to take into consideration member familiarity with some of these foods. Sarah mentioned that not everyone may know how to cook an eggplant. Turns out some people didn't know what like a rutabaga was. Or there was an instance where we had some phenomenal zucchinis, and people thought that they might have been a cucumber, or plantains and bananas come together very, very frequently. So knowing and having an idea of what members are familiar with, so that you can have an idea of what to use, because you want them to use this food. So the primary purpose, make sure they use this food, start with things they're familiar with, and then take some opportunities through education, through recipes, to introduce more different vegetables, more different fruits, and then always having a conversation on allergies, so that you can mirror and move some of these people's boxes if they have a lactose allergy, for instance. Next slide, please. Sourcing food has been one of the most fun portions of the project, and as the project and program has grown, we have had to change the way that we source a lot of our foods. In the very beginning, we shopped shelves. We went to local grocery stores, and we're like, okay, we want some of this today, and we want some of this today. And for a while, it worked, but it is extremely high intensive for time. It is taking a lot of staff, a lot of time to go and do those shopping orders. The nice part about it is you have no waste. You know exactly how many boxes you're purchasing for either that day or that couple of days. But I would also talk with you and urge you to communicate with that store leadership, so that we know what is happening and they know that if something is in need. From there, we went to special orders. We were able to work with those stores and say, we really need a lot more of X, Y, and Z. Can we start ordering from this in more bulk? And then we would start getting pallets of different items. And finally, where the goal is to be working with your local farmers, whether they be in your county that you are or around the county that you're in, for the freshest fruits, the freshest vegetables you can get. There's other options that I would give as examples, working maybe with third-party distributors and have them tell you who the local farms are, so that you can have those individuals work. One of our cohort, another member who's doing food boxes, they work with 27 different local farms, and they have a full-time staff member who just works with those farms, and that's been phenomenal. Next slide. When you're thinking about distributing those pieces, it seems the most of us have really leaned towards either having in-house drivers or a third-party option to have a third party deliver that out. When you're thinking about which way you want to go with this, I highly recommend looking at a routing system, depending on how many stops you're going to have. And as that grows, is that system something that can scale with you? And then the more stops you have, the more vehicles you're going to need, and the more maintenance that those vehicles are going to need. Next slide. Sarah talked quite a bit about this, and I think it's really important. It's why we decided to move 100% with our own drivers, and that's that stable drivers and consistency create trust inside of our members' lives. They give us those success stories, and they help us find more wraparound services that those people might need. And our last slide that we're going to talk about with me is the community engagement. As you're putting these things together, in April, we had almost 1,400 hours of volunteer service. We've had people from 3 years old to 95 years old who have been helpful in helping us craft these boxes, putting boxes together, working inside of our refrigerators and freezers. And what it's doing for the community is showing the need of food insecurity, showing that it's our neighbors who are in these programs, and just how much this has been able to help, not just those individuals, but also our families, our friends, our schools are getting involved, our churches are getting involved, and the whole community is really coming together and recognizing that food is medicine. Thank you for your time.
Okay, sorry about that. Hi, so I'm Seth Berkowitz. Lucky to be on a panel with the folks who are actually doing the hard work of getting these programs out to people, and I just get to evaluate it and see what the effects of health are. I'm going to be talking about some results from what's called the interim evaluation of the Healthy Opportunities Pilots program. So as many people know, with 1115 waiver programs, CMS mandates evaluation at a couple of different touch points throughout the process. And so this is the sort of most recent evaluation we have, although as you'll see as I start presenting the numbers, it still is a little bit behind, and that is just sort of the nature of the beast that these programs keep going, but you need to kind of pause and take stock somewhere to do it. And I just want to be clear that this is all joint work with a great and talented team listed here. I always just like to announce disclosures. So this work was supported by a contract from the state of North Carolina, and then the rest of the research team has an evaluation team, I guess I should say, has the following list of disclosures generally for research around these topic areas. So I'm going to go through these first couple slides quickly because Sarah did such a great job of explaining what the pilots were. But again, just to note that these are results from sort of the midpoint of the first pilot period. I'm going to skip this overview. And then I'm just going to briefly reiterate some of the things we've been talking about, which are that you can get pilot services across a number of different potential needs. So food, housing, transportation, interpersonal violence, and cross-domain. Food winds up being the majority of services delivered, particularly if you count by like discrete services. With that said, housing might be a smaller number of services, but a higher dollar amount per service. So that might be a different way to think about it. But even looking at dollar amount, food still is kind of the lion's share of services delivered. But that doesn't mean that the other services being provided are unimportant. The interim evaluation report uses data through 2000, basically the end of 2023, which is about 18 months after HOP started delivering services, or about halfway through the period. Because things sort of ramp up slowly, even though it's about halfway in time point. As Sarah showed earlier, HOP has now served over 40,000 people, so this is really only about a third of the total people served during that period, but it was about half the time. About 90% of people who enrolled in HOP got at least one service, so it was reaching a pretty high number of people. And the median time from enrollment to actually getting that first service was 7 days. So that's pretty fast, I think, in the context of a healthcare delivery system. You can think about how fast people might be to get an MRI or something like that, and put that in context. Across the state, there were about 150 different human services organizations that provided at least one service. The invoices were paid relatively quickly, so about 75% of invoices were within 45 days, and over 90% were within 90 days. And at the time of this evaluation, there had been about $36 million in service spending. It's since grown, obviously. So one way to think about, is HOP having its intended effect? Is it reducing social risk factors? The sort of logic model of what's going on is that, HOP is providing services. These services address social risk factors. Without those risk factors being addressed, they can sort of undermine the benefit of clinical care. So imagine you might otherwise be getting effective diabetes care, but in the face of food insecurity, that diabetes care isn't going to work as well. So if you can resolve the food insecurity, then your diabetes care may work better, and people get healthier. And so there are a couple of different ways to look at whether HOP is improving social risk factors. One is to just sort of look at the total count of risk factors. And here, using an interrupted time series evaluation, we estimate that HOP is reducing the total risk factors. Relative to what we would call the counterfactual, what we think would have happened in the absence of HOP, and that this was apparent both overall, but also across a number of the different eligibility categories within HOP. And so the key thing to pay attention to here is this trend part. This is on a per day basis, so the magnitude of these numbers is small, but you don't expect risk to change very much on a per day basis. But the key thing is that there's sort of a negative declining trend overall across all the different sectors of people who are eligible for HOP. Another way to look at it is, well, what would the probability of a specific need, so not the total number of needs, but any specific need be either without HOP or with HOP? And so here again, you can see that there's a differential in favor of HOP, such that the probability of any particular need is lower when people are participating in HOP than we think it would have been if they had not participated in HOP. These three, the food, housing, and transportation needs, are all statistically significant differences. The IPV and toxic stress need was not a statistically significant difference. However, the magnitude was very similar to these other needs. And because these needs are reported less frequently, it doesn't necessarily mean they're experienced less frequently, but they're reported less frequently. There's much lower power for these needs, and the services to address these needs came on board later in the HOP period. So overall, I think this is consistent with HOP addressing these needs. But I just want to note that it's not statistically significant in that one case, but I think for understandable reasons. All right. Well, if HOP is, reducing these social needs, do we see potential benefits of that in some outcomes? And so, in the overall evaluation, we're actually looking at a number of different outcomes: clinical outcomes, patient-reported outcomes. But for the interim evaluation, the sort of data that got to us first was utilization and cost data, and so that's what the interim evaluation focused on. Not that I think those are, the only important outcomes or the most important outcomes. That is just sort of a product of how the data is getting fed into us. We do have analyses planned for, a wider spectrum of outcomes as well. And those will be part of the summative evaluation report, which will be submitted to CMS next year. For these cost and utilization analyses, we used a comparative interrupted time series design. So we basically looked at people in HOP before and after they started HOP, and then we looked at a comparison group of people. So these were North Carolina Medicaid beneficiaries who similarly reported a health-related social need, and thus likely would have been eligible for HOP had they lived in a HOP county, but they just happened to live in a different part of the state where HOP wasn't on offer. And so we thought this was a good comparison group because there are people who are otherwise exposed to the same changes in the North Carolina Medicaid program, changes in the North Carolina economy and policy environment, and all these things, but they just differed in whether they could get HOP or not based on where they lived. We looked at all HOP participants, and this is what I went through about the comparison group. For the actual analyses, depending on how statistically minded you are, we use gamma regression analyses, so generalized linear models with a gamma distribution and a log link function for cost analyses, and then Poisson models for utilization analyses. And then in addition to the sort of inherent adjustment that comes in a comparative interrupted time series analysis, because you're comparing the same people over time, we did this on a sort of person month basis where people were followed for 24 months, 12 months before their index date, and then 12 months after. We also adjusted for some observed characteristics like age, gender, race, and ethnicity, et cetera. And so in terms of cost of care, the sort of main thing to focus on in an interrupted time series analysis is what's called a change in level and a change in trend. So change in level is a difference in an intercept of a regression line. So you can see if in the sort of pre-HOP period, the trends were going here, and then you see a jump around the time of HOP enrollment, which is partially the spending on HOP services. So you expect services are coming on board. There's going to be spending around that, but also sort of reflects the situation people are in. So many times people sign up for HOP after an emergency department visit or a hospitalization or something like that. And so there are clinical changes going on that are reflected here as well. And then you see a declining trend in spending over time. And so together that declining trend is the slope of the regression line. So you estimate a intercept and a slope of this new regression line. You compare it to the comparison group, and then you take the difference of those to get your estimates. And so what we see is that there is a differential increase in spending around the time of HOP enrollment. That's expected. Again, services are getting started. There are medical events going on that cause people to enroll in HOP. And then there's a declining trend in spending over time. So this is on a per month basis. So spending is declining relative to what we think would have happened in the absence of HOP. So had people had all these same kind of triggering events and everything, but not had HOP, we think spending would have trended higher. But with HOP, we think it trended lower in a statistically significant way. Um, and then, one question might be then, well, where is that coming from? And so, we often look for reductions in healthcare utilization because those are sort of particularly expensive forms of healthcare services. And we do find that using the same analytic approach, HOP reduced emergency department visits overall and for all subgroups. And then HOP had sort of a heterogeneous impact on inpatient admissions. Inpatient admissions are relatively rare outcomes. Adults are at the highest risk for them, and most of the inpatient admissions occurred in adults. And we did see a statistically significant reduction in inpatient admissions among adults. In the other groups, we did not see a statistically significant difference with HOP. And overall, the trend was negative, and the p-value was like 0.07, taking everyone. So sort of borderline statistically significant, taking everyone. But again, in adults in particular, that was where we saw the statistically significant difference for hospitalizations. And then the last bit of utilization, I think you have to think of a little bit differently, and that's outpatient visits. So, I think it's, although it's of course good to go to the emergency department if you need to, it is better if you're not in need of going to the emergency department. And so in general, I think as long as access to the emergency department is preserved, we can interpret a reduction in emergency department visits as a good thing, as people being in better health. With outpatient visits, it's not so clear. So on one hand, not needing as many sick or sort of acute visits or unscheduled visits in an outpatient setting could be an indicator of good health. On the other hand, attending more preventive care visits or chronic disease management visits might be a good thing. And so there's kind of not the same interpretation. However, there was interest in just understanding how outpatient visits evolved. And the main takeaway is that there was really sort of no difference in how outpatient visits evolved in the HOP group relative to the comparison group. So probably no impact on outpatient visits. Just one way or another. So just to summarize again, as of the interim evaluation report, this was a study of about 13,000 people, about 90% of whom received at least one service. Services generally started pretty quickly, so soon after enrollment. We saw a reduction in total number of needs and a reduction in the probability of specific needs like food insecurity and housing instability. We saw lower emergency department visits. We saw lower inpatient admissions in adults and no real effect on outpatient visits. And all of this kind of taken together netted out to an increase in spending around the time of HOP enrollment, but a decreasing spending trend as people stayed in HOP and received services over time. There you can read, sort of all the nitty gritty about this in a peer-reviewed paper and then a report that was submitted to and approved by CMS, which the QR codes will take you to those papers there. So that has even more. And then just to sort of think about some of the implications. So food services were definitely the bulk of HOP services by the number of services delivered and also by spending amount. However, I really do think some of the secret to the success so far, at least of HOP, has been its flexibility in that, just because you report food insecurity doesn't mean that the only type of intervention you can get is a food intervention. If you're also having, transportation needs or housing needs or things like that, all of that can be worked on in kind of a holistic way, and it's delivered as sort of a partnership. interventions that are offered, the person and the care manager can kind of come to understand what is most likely to improve someone's situation. And so I do think that flexibility is important. And I think overall this contributes to sort of a growing evidence base around food and nutrition interventions or food as medicine interventions. Right around the time that we published results here, my colleague Kurt Hager in Massachusetts and a team that he worked with published a great study of a similar in spirit, I guess, health-related social needs, Medicaid 1115 waiver in Massachusetts, but that used a very different structure. It was an ACO-based structure, different framework and everything, and they saw very similar results to us. And so Kurt and I have talked a number of times, and it's very reassuring that two different approaches that are trying to address the same things but doing it in different ways seem to both be having positive impacts on health outcomes. And then this is just another review, although these reviews almost become out of date as soon as they're published, just because there's so much work going on in this area, but a review of food as medicine interventions recently. Just in terms of limitations, so again, in this interim evaluation, the data that we were using were mostly, sort of secondary, claims type data. And so there can be errors with that. We don't think those should be differential across the groups, but it's something to be aware of. And then, fundamentally, these are not randomly allocated services. We think we used a pretty strong evaluation design to try to take into consideration as many of the factors that might have influenced some people versus others to get HOP services, but ultimately with a non-randomized study, there's always some questions there. So I think I'll wrap up there. That should leave time for questions in the seminar or webinar. Sorry.
Amazing. Thank you so much to all of our presenters. We're now going to begin the Q&A portion of the webinar. Again, we encourage you to submit questions through the Q&A icon located at the bottom of your screen. We have a very diverse array of attendees today, from providers to CBOs to government officials and health plans. So any question is a good question. So pop them in there and we'll get to as many of them as possible. I invite Sarah to come back on camera as well. There's a lot of great questions already coming through the chat. We know that food is medicine, but it's also so much more than that. It's family and culture and flavor and dignity. There's a few questions about this in the chat, but what approaches are you taking to support culturally appropriate food choices? And I can tag CJ in for that one.
Yeah, please. So as we talked about in the question and answer, the platform that our drivers use to get to all of the different stops they have includes a texting platform that participants and members can use for feedback. They can tell us what they like, what they don't like, and we also throw out other surveys. We use that data to then inform our things moving forward. We're in eastern North Carolina in Onslow County. We're the top portion of Sarah's map there in the southeastern portion. I have now learned that there are over 70 different kinds of collard greens, and that was really important because we had started with some collard greens, but didn't realize the way that they were cooked, and we needed some educational components to try to change the way they were cooked and the ways that they were added to make them a bit more of a healthy component. We've moved some of our grains to grits for individuals who have really pushed into that message. And there's a lot of different ways that we've also not changed maybe one of our items, such as our cereal. So whole grain cereal is not kids' favorite, is what we've learned. However, one of our food case managers is a chef, and she's like, oh, well, if you crunch up this and then you can use it as a crunch topping in some other ways, and then included that in some of our recipes and educational components. So always at the top of the mind, how individuals are going to use these boxes, again, to the top priority that we want to make sure that individuals do eat the food.
Awesome. Well, I just learned that there are over 70 types of collard greens. So Sarah, you spoke to the economic impact of a program like HOP for local communities. There is a question in the chat of, will the HOP evaluation assess impacts on farmers or growers who are engaged, whether from their lived experiences or quantitative metrics like food waste avoided, income generated, et cetera?
Yeah, so that is not being done necessarily at the state level at this time, but that is being done regionally. So I know that there's a lot of work around talking with farmers, seeing what's going on in the western part of the state. And then we have a tremendous amount of qualitative data, a lot of stories, and just shared experiences with the farmers who are working within HOP.
Awesome. Um, there's a few questions about the period of time for HOP service provisions. For example, the Michigan pilot is limited to 6 months but can be renewed. Can you speak to the duration of the pilot for services?
Yeah, during this first demonstration period for HOP, so HOP was one of the earlier Medicaid 1115 waivers that addressed health-related social needs to get approved, and so actually it was approved before what became what was called the HSRN framework or guidance that the Biden administration ultimately put in place and then was subsequently rescinded earlier this year. HOP was actually approved before the Biden administration. And so there was not a formal stipulation of time limits on services as part of what are called the special terms and conditions, the actual regulatory requirements of the program. In practice, it was rare, although not impossible, that people could receive services beyond a year. But in general, many of these needs are sort of episodic, and so even without sort of structured limits, people often said, "I just don't need services and anymore. My need has been resolved." But the short answer is in the initial HOP program, the SDCs did not contain those. In the HSRN guidance that subsequently came about, and that many other states, both 1115 waivers or in lieu of services like in Michigan and others, came through, there was more time limits on it. And for the way that the next demonstration period in HOP, if it does continue, there are time limits associated with that based on the way that CMS structured their requirements, basically. But for this period, it was sort of before a lot of those limits were in place.
Awesome, thank you. Um, Someone has a question about, were there any early implementation challenges either for Medicaid health plans or CBOs that you'd provide advice to for overcoming in other states? And I'll pass that to Sarah and CJ respectively.
Yeah, I definitely, because, again, we're talking about maybe two different types of stakeholders that haven't worked together before, right? So when we work with a lot of our human service organizations or community-based organizations, they may have not had experience as a Medicaid vendor previously, right? So there was a lot of capacity building opportunities in the beginning. There were capacity building dollars provided to HSOs and CBOs in the beginning. And in part, that was for training and technical assistance. And then, of course, when you talk about our health plans, our managed, like a lot of it again was more around invoicing and reconciliation practices, right? So HOP is a reimbursement model, and it took, I think, probably in the beginning, CJ, you can correct me if I'm wrong. I would think that was probably one of the biggest barriers we experienced, was making sure that the health plans and the HSOs and the technology platform we were using all worked together smoothly. So there were some barriers to work out in the beginning. But again, it's a pilot, right? So there's an evolutionary process to that where you're really working to reduce those barriers.
Absolutely. Thanks, Sarah. Yeah, my Wi-Fi network is called It's a Pilot, so it is certainly words that we use quite a bit. It should probably be the password as well. I would say, as other organizations are looking to get on board, the hardest part in the beginning was figuring out how to scale as the program was growing. Where are those economies of scale? When do you want to start having those conversations with local farmers, knowing that if you are taking items that they're currently harvesting, or are you asking them to plant new things, having those conversations with store managers in your local stores about, well, I might need 100 loaves of bread next week. Can we facilitate that so that other members who are coming to your store don't, or they do have those options still available to them? So having those conversations with your food sources are just very critical, and getting those relationships in place, finding out the time frames, what to grow. Right now in North Carolina, strawberries are on their way out and blueberries are coming in phenomenally. So planning your boxes and planning where things are coming in is really important.
Awesome. Thank you. Um, this next question I'll give to Seth. Someone in the Q&A asked, do you have an average cost per participant in HOP versus healthcare cost savings? How do you show ROI? And more specifically, trying to understand if the reduction of $85 per month takes into account the cost to deliver the program, including labor and non-labor. So a bit of a nuance there.
Yeah, so the all the numbers about healthcare spending, HOP spending, broken down in a lot of detail is in the full evaluation report. I won't quote them off the top of my head because I'll probably get it slightly wrong, but they're definitely all there, and people were quite interested in them. In terms of what goes into the cost, so we look at what is paid by the state through the prepaid health plans. And so from the state's perspective, and I realize there are other stakeholders on the call, but from the state's perspective, that is what's being paid for. It's being paid for the actual, all the inputs, the labor inputs, the food inputs, all these things are what being paid for the services. There's a fee schedule. There are differences of opinions about how well the fee schedule matches up with the actual costs experienced by the organizations that I won't get into here. But so what we look at is what the state is paying, which at least theoretically is meant to be the cost of delivering the service, and then we're also looking at the healthcare expenditures as well. So that's what we see. Knowing how these things work, I wouldn't be surprised if there are some costs that organizations are not able to fully recoup through the benefit through the sort of per service rate, but.
Thank you. So there are a few questions addressing the elephant in the room, but in response to recent news that North Carolina may end the HOP initiative early, there's a few questions about how to make sure services are either continued or sunsetted in a way that isn't harmful to Medicaid members.
I'm happy to jump in, and I'm sure others can contribute to this. I think that is a real challenge. I mean, right now we're experiencing where we are having to kind of stop those services based on what's currently happening in the North Carolina General Assembly. And HSOs are working incredibly hard along with network leads and the care managers to really make sure that those members are getting those final set of services, but also looking into transitions of care if that is possible, right? So, because, we have members that may be in medical respite or, other services. So it really is leaning into a couple of different things. What does that health plan have for that member that may be an additional benefit that they'd be eligible for, like a value added service? And then, of course, what are your local resources? I think the challenge there a little bit is we're seeing other local resources also experience some challenges. So it is becoming a little more difficult potentially to find food, to help somebody. And then, I think about kids going into summer, right? They're not at school, so they're not getting those free or reduced lunches. Cost lunches. So, there are some challenges in that.
I don't know if CJ or Seth, you want to comment as well. I know it's hard
Yeah, I
to
think
say.
Sarah did very well answering that. I still have hope that there will be Medicaid transformation funds when North Carolina finishes their budget. I don't believe at this time, we're being recorded. I don't believe at this time that that's going to be by June 30th by their deadline. That seems a little far. However, I believe that food is medicine. Amanda, you said it very well. Food is so much more than medicine. And to answer one of Carolyn's in the chat, food is also community. Those drivers who are making those deliveries and having those conversations with people, we see that through our soup kitchen every single day. We are telling participants about our other food distributions that we have and do, our soup kitchen off hours. And that's, again, we're getting that local community involved this entire time has really helped. We have multiple other organizations who haven't been involved in HOP now doing more services around food throughout the summer. So I'm very hopeful that our members aren't going to be negatively impacted too much. Certainly it's going to be different, but still very hopeful.
Awesome. Thank you. Well, I know we are just approaching the end of the hour, and I really appreciate everyone's very human-centered answers to all of the questions because at the end of the day, these are whole people that are receiving services. Um, we can pull back up the slides really quickly. Again, thank you to our amazing presenters today. We are so lucky to have had you join us, and thank you to all of the attendees in the audience. I hope you all are walking away with more understanding about how to implement a program like this and the value of evaluating such a program. Just quickly here on this slide, you can see some resources, including a Better Care Playbook collection on nutrition interventions, Dr. Berkowitz's published article on the HOP evaluation results, and a few more related CHCS publications. On the next slide, just feel free to contact us if you have helped to develop any evidence on what works about nutrition interventions in healthcare or just other evidence or best practices for improving care for adults with complex health and social needs. We encourage you to submit those resources to the playbook. And then finally, there will be an evaluation that pops up on your screen as you exit the webinar. We really appreciate your feedback, and it will help us publish content that better meets your needs. So again, thank you all to those who joined us and to the amazing presenters that we had today. We're so grateful, and we hope you have a great rest of your day.